Next slide, please. We'll quickly move through our agenda today. We'll talk a little bit about the housekeeping, some of our learning community objectives. We're having participants go ahead and introduce themselves in the chat. We'll have a poll question, and then we'll hear from our subject matter expert and guest speaker, finding the right supports at the right time, Nicola Winkle, and then we'll have a short facilitated discussion. Next slide. Next slide, please. After we have that facilitated discussion, we'll hear from our next subject matter expert and guest speaker, Mr. Dwayne France, who will talk to us about engaging families in the treatment process. We'll have one more facilitated discussion. After that, we'll look at next steps and adjourn. Next slide, please. So many of you have been on these learning communities with us, and by now you probably know this by heart, that you will identify yourself when you speak. We ask that you put your computer speakers and phones on mute when not speaking. These are designed to be very interactive sessions, so we ask for full participation as much as you can and keeping others in mind. Thank you. Next slide. So some of our learning objectives for this community, participants in this learning community will be able to, number one, identify best practices to ensure families connect to the right supports at the right time. Number two, discover tools and resources available for connecting military and veteran families to mental health and substance use services. And number three, demonstrate the importance of engaging families in the veterans treatment process. Next slide, please. So as we've stated earlier, we'd like for each participant to go ahead, take a minute to introduce yourself, your name, your agency, and the state team that you're representing today. Most of you have already done that, so we'll move on to the next slide. This is a poll question, and we're going to ask that you just put the answer to this question in the chat, and we'll have discussion later on after the guest speaker, after our first guest speaker has completed her presentation. We'll discuss this a little bit more. The poll question is, have you ever assisted a service member, veteran, family member, or caregiver in getting connected with behavioral health services? Yes, no, or simply, it's my job. So if you go ahead and put your answer in the chat, we'll wait a few moments while we get those answers, and then we'll move to the next slide. Okay, thank you very much for completing that. At this time, I have the wonderful opportunity of introducing our first guest speaker, Ms. Nicola Winkle, MPA. Ms. Winkle is the project director for the Arizona Coalition for Military Families, a nationally recognized public and private partnership focused on building Arizona's capacity to care for and support all SMVF, as well as communities. She has also had a principal role in the development and implementation of Arizona's Be Connected program. This program focuses on upstream prevention to positively impact social determinants of health and decrease the risk of suicide. Ms. Winkle has worked for more than 20 years in the nonprofit community, specializing in program development and implementation, bringing a mix of planning, project management, communication, team coordination, and problem-solving skills that drive execution of complex projects and build sustainability. Wow, that's very, very impressive. In addition, Ms. Winkle has provided consulting services for state and national initiatives, including the Be Resilient program with the Arizona National Guard, continuing education programming with the Western Interstate Commission for Higher Education Mental Health Program, project management of a DoD study on mental health education within the National Guard, including adaptation of the mental health first aid curriculum for use with the military and veteran population. She assists with the development and implementation of the White House Prevents Initiative, which is focused on veteran suicide. She is briefed at numerous local, national, and international conferences. Ms. Winkle holds a master's degree in public administration from the University of Illinois and a systems thinking certificate from Cornell University. She was awarded the Adjutant General Medal by Major General Hugo E. Salazar for her efforts in implementing the coalition and strengthening support for Arizona's military, veteran, and family population. She has been recognized as one of the 48 most intriguing women of Arizona as part of the state centennial. Please join me in welcoming Ms. Nicola Winkle. Thank you.
Thank you so much, Barbara, and good morning, good afternoon to everyone. It's great to be with you today. I know some of you were on the previous team lead call just before this as well. I'm really happy to be here today to talk to you about helping military and veteran families navigate systems. I'll talk first just a little bit about sort of how we have things set up in Arizona, sort of how we approach things, just to give some context for the things that I'm talking about, but then I'll get into just some overall strategies that can be applied in different settings and systems and in different programmatic kind of settings so that you could adapt those to use in whatever you have deployed in your state or community. So we'll start with that and then we'll dive in. So next slide. So I'm with the Arizona Coalition for Military Families. As mentioned, we're a public-private partnership, collective impact initiative, and we're really focused on our entire military, veteran, and family population, as many of you are. We established the coalition in 2009. I was part of the team that created it. It was based on an extensive needs assessment. As some of you may recall who have been involved in this work for a long time, that was really the height of the post 9/11 deployments. There was a lot going on at that point, and really the intent of our effort, and like so many of your efforts across the country, is really to be that connectivity point between military, government, community, public and private, and to create as much, maximize as much as we can the impact of the resources and the coordination and collaboration that we have. Then in 2017, we launched our Be Connected program. This is our Upstream prevention program. We have about 500,000 service members, veterans, and families that live all across our state. And we really focus on all social determinants of health. And that becomes really important when we talk about the topic we're focused on today, which is connecting people to behavioral health systems. But our sort of working theory is that we don't want to zero in too much on behavioral health because that may be the door that somebody walks through, but there can be many, many more ways that people present. And the wider we open that door and the broader that we look at the challenges and stressors people face, the better opportunity we have to connect them to whatever it may be that is impacting them. And whether that kind of presents as a sort of more traditional or sort of focused behavioral health issue, or whether it looks like something else, we want to be as inclusive as possible when we are making those connections for people. Next slide. So this is our ecosystem of support, and I know it's not going to necessarily be legible, but I'm going to show a video in a second that just kind of illustrates again sort of how we approach things in terms of looking at it as completely as possible, and that we really truly do look at this as an ecosystem of support. So not just one organization, entity, system, but a whole interconnected ecosystem of people, organizations, and systems. We never know where people are going to interact with or connect with that ecosystem. So we must equip and connect all of these different pieces. So this is sort of how we sort of view our community and what we have to offer and how we can support people. So I'll just show you this quick 2-minute video that provides an overview of that ecosystem approach. So I'm not hearing any sound.
When you shared your screen, Nicola, did you click the boxes to enhance your video?
I'm not sharing, so I think, yeah, there's usually a box that you have to check when you share that. I think it's like share audio or something, right? If it doesn't work, we can just move along. It's fine.
Our technician Phil is definitely managing that, trying to figure out what might be going wrong, Nicola.
And actually, you can go ahead and play it. I'll just sort of narrate it.
Arizona is home to more than 500,000 service members, veterans, and their families. There is an entire ecosystem of support available to everyone, all ages, family members, stages of life, and military affiliations. This ecosystem includes a variety of helpers from the community, as well as partner organizations that come together to address every area of life. Because every person, family, and situation is unique, there is no one-size-fits-all approach. The ecosystem of support takes into account different factors to find the custom combination of resources to address each person and family's specific needs, with an upstream goal of addressing issues and preventing crisis. For example, a 67-year-old veteran recently lost his spouse. He feels isolated with little connection to the things he once enjoyed. Be Connected can link him to resources to foster social support to combat this isolation. A 39-year-old service member is transitioning out of the military. She's worried about starting a civilian career. Be Connected offers career navigation, including resume building, interview prep, and connection to Arizona veteran supportive employers. The spouse of a veteran calls Be Connected because her family has had a loss of income and is struggling with meeting their basic needs. Be Connected can help with referrals to immediate and ongoing resources. How can the Be Connected ecosystem of support assist you, your family, and others in your community? Our team is here for you. Visit connectveterans.org or call 866-4AZ-VETS.
Okay, so sorry that was a little bit choppy. I know the connection wasn't great, but the concept we really wanted to get across for our community as we really invite people into this ecosystem to be helpers is this idea that when you kind of rotate those rings, you can come up with sort of endless combinations of what needs people might have. Oh, thank you so much for that comment, Angela. What needs people might have, who they might interact with in terms of helpers, and then what kinds of resource needs they might have, and what kind of resources we might connect them to, this idea that it is sort of in motion for any one person and then certainly over time. So that's sort of the idea behind it. Our approach is a public health approach to suicide prevention, really looking at this idea that we're not going to use that same approach for every person or family, and that we absolutely do need crisis response and treatment, of course, but we also need proactive prevention. And I think that this has been a challenge in sort of a cohesive and comprehensive way. So we use this prevention model, the universal selective indicated as sort of the framework for how we are approaching things with our Be Connected program. Next slide. So this concept of there are things we do for meant to reach everyone, right? So the universal things that we do. We have a campaign right now running with our Arizona Broadcasters Association, where they partner with different government agencies and nonprofits to put public service announcements out on TV and radio. So those are general messages, encouraging people, educating them about that this resource exists, that there is help out there for these things, and encouraging them to call or to connect people to the resource. So that's an example of something we're doing for everyone. Next slide. Okay, so then selective is looking at segments based on higher risk. So we have spent the last about year and a half working on a project that was initially funded by the CDC and CDC Foundation that we have focused on taking known existing data and combining it in ways that help us understand what segments of our veteran population are at greatest risk. And so through that analysis, helping us to know what are some parts of our veteran community that we need to have particular focus on in terms of those segments of the population. These include things like veterans who either have a disability or suspected of having a disability, since we know that is a predictor of suicide. Also geographic factors, other factors that are all put together. So that's where we're looking at, okay, how can we then focus in on that segment? What are some proactive things that we can do for those individuals and families? And then the last one is indicated. So this would be where we are figuring out what are certain encounter points with our ecosystem where people can be identified and then directly referred or connected or intervened with in some way. The next slide. So the question is, how do we help families more effectively navigate systems to connect to resources and support? I mean, we all have the experience of there is so much out there, in some cases, so much that it's overwhelming. Being able to give people sort of simple direction about what to do next isn't always, completely obvious how to do that. And so we have to really kind of think about what are our strategies and approaches in order to do that. So next slide. So the first thing that, I wanted to just kind of mention was this idea of really looking at who and what is the focus. So of course we have our service members and veterans, like that's obviously the reason that everything that we are all doing, the core of it is the person who has served in the military, either now or in the past. What we really want to push beyond, though, is I think there is a tendency at times, and I think there's probably a lot more attunement to this in this group than perhaps maybe others, but there can be a tendency to view family members only in relationship to the service member or veteran. So that their needs become about the needs of the service member or veteran versus looking at that person as someone who might have their very own needs of, their own needs as an individual person that might not be about their service member or veteran, might be just about them. And I think it's a really important message that we are continually putting out there, that it is not only, that is the case, but that it is important to us as a service providing community, that their needs matter to us, and that we feel like it is important to attend to them independent of what their service member or veteran might need. So, you've got their, they very well may be advocating for or trying to assist their service member or veteran with getting care or support. But then we also want to look at, they might have other family members, they may have children, they might have other family members that need help, but they themselves may need things too. And you, of course, could have a combination of all those different people. So we just want to make sure that we're sort of centering who we need to focus on, and again, be inclusive with that. Next slide. We want to focus earlier. So this is the Stress Continuum that was originally developed as part of the Marine Corps Navy Combat and Operational Stress First Aid, and we've adapted it for use in Arizona this idea that, green, yellow, orange, red provides a fantastic language to talk to people about where somebody is at. We even use this in our referral process just so you can communicate succinctly from one team to another, where is this person and what's their acuity level. But really, our overall goal needs to continue to be earlier intervention to have a positive impact on the social determinants of health, and not let things get so far down the line that you are moving into that orange and red zone where it is the timeliness is so much more important, and the resources are much more intensive. If we can do more when people are green, yellow, light orange, we're going to have better outcomes over time. Next slide. So how do you get more into the green or yellow zone? So some of the strategies that we use really open the widest door you can with the resources you have available, so that really you are making that all inclusive, like service members, veterans, family members. I mean, our door is really wide open in the sense that, like, we're not just like immediate family members, but extended family members. We get all sorts of calls from all sorts of people, and what the message that we want to be able to put out is like, hey, you can call anytime for anything. We want to really equip our community to assist across the whole spectrum of need. And that means all the focus areas, which I'll talk about in a second, the levels of acuity, to help them know that, like, you are not expected to be able to do everything, but here is the number you call if you need someone to help you help somebody, basically. Consider your language and messaging. So we use support line, we use community navigation, we do not use crisis line or crisis navigator. You will see very few limited references to suicide in our sort of outreach materials. And the reason for that is because we are trying to encourage people to call at any time, not just when they're in crisis, but when things are going fine, but they need help with a resource, or if they're starting to experience stress, we don't sort of want to put this qualifier for them on there. And so really keeping that language sort of as broad along that spectrum as possible has been really helpful. We did a whole kind of study and analysis of our Be Connected support line at one point, just to see, like, what was the acuity level of people calling. And we found that, about 85% of the calling calling were what we considered low acuity. And that, to me, said that we were actually accomplishing our mission, which was to connect to people before they ended up in that crisis zone. And then, encouraging people to make contact for all their needs. So many times we have so many stories of people where the immediate need is not necessarily the ultimate need, right? And so we had this example of, someone who contacted the line because he had a pet and he needed help caring for that pet. It was sort of a very specific kind of pet need. And we were actually able to find a volunteer to help with that pet. And what ended up coming out as we, this person helped this veteran, was that he really needed to go to substance use treatment. He needed to go to a 28-day substance use treatment program, but he wasn't going to go because his pet was not going to be, he had no one to take care of this pet. And the volunteer in the end offered to take care of the pet so that he could go. But that's just a really good example of, like, okay, let's start with the thing that this person feels like is their need, and then we can move on to maybe other things that will emerge from there. Next slide. Encouragement to think broadly. So we are operating with social determinants of health. And so not necessarily just zeroing in on behavioral health or mental health, but really looking at all of the things that can affect a person's life, their livelihood, their stress level, their ability to function. And so these are the 10 kind of kind of categories that we look at in terms of social determinants of health, most everything that we've ever kind of come across or come up with has fit into these 10 in some way or another. Perhaps maybe there's something that falls outside them, but in general, like these are going to cover it. And again, like knowing that all of these things can have an effect on a person's mental health and their well-being and their ability to function, we sort of, in a way, want to treat them equally in the sense that these are all things that we can and want to assist people with connecting to resources and support for. And so we'll have different situations. I mean, some people make contact and like they just want one thing and they're good and they go on their way, and that's fine. But we have had a lot of other situations where we like to take the opportunity to kind of do a full needs assessment with somebody, kind of walk through what their situation is and see what we can identify in terms of their needs. Next slide. So, and that's just, to keep in mind the point that from the last couple of slides, which is just that the point of engagement may not be mental health. I mean, that may not be your entry point to connect somebody who is maybe not connected or is just in a period of time where they need additional support. We did a recent project focused on households that have been impacted by COVID-19 who had essential needs that they needed assistance with. And of those military and veteran households that we served, 71% of them had experienced difficulty meeting basic needs. So that's food, utility bills, gas, healthcare. 38% of them or their family members had experienced illness, and 40% had experienced a reduction in hours or income. 60% had experienced more than one negative impact from the pandemic. So again, I think if our focus is just on behavioral health, we might miss a lot of these things, and these can often be great bridges to connect people in who may not be connected, and to build that trust so that you can continue on and help them hopefully address other needs as well. Next slide. So you want to just kind of think about what is available in your state and community to connect people to resources and support. Like, what are some avenues that you can provide to people that are really clear and that can take the capacity that you might generate by sharing that approach or offering. And then I think the follow-up question to that, because we obviously have some wonderful resources out there, amazing things that are there to help people. I think the next question always needs to be, then how can the process of getting help be simplified? So, I can tell you how many times, it's generated just huge lists of resources and links and phone numbers. And I mean, there are some people who can do that, but I think a lot of people don't necessarily have the capacity when they are under stress to understand who would I call, why would I call this number versus this number? A lot of times there's just not a lot of context provided, like call this place for X or this place for Y. And so we just want to think about how do we make it as clear and simple as possible, and if possible, reduce the points of entry so that you make it as streamlined as possible for people to get that help and support. Next slide. So we want to keep in mind that people will often feel very overwhelmed at a time when they need resources. So, again, handing the list over or giving a lot of different options, that can be really challenging for many people. Some will be fine with that, but for others, it's going to be a real challenge. And so I think whenever possible, if you have this type of resource available or a way to sort of coordinate this for people, is to provide resource navigation. And so to me, the difference between resource provision and resource navigation is again, the difference between sort of handing over the list or just connecting someone to a website or something. And resource navigation to me is more about finding out what their situation is, what their needs are, and then helping them to sort of navigate that landscape and determine what is going to be the right fit for them. If they encounter barriers, which of course would be normal for that to happen, unfortunately, helping them navigate around those barriers. There are so many ways in which we can often, as service providers and programs, can smooth the way for people and sometimes untangle something that would take a family, an overwhelmed family member, a really long time to figure out. Sometimes that can be done very simply on the service provider side. And so wherever possible, provide resource navigation. And then the other thing I'll say is to look at how we equip organizations and community helpers to provide effective care, support, and connection. So this is something going back, over a decade that I know many states have been working on and communities, which is that it is great to have people who want to help. It is even better to have people who want to help that are equipped to do so. And that just means that they have an understanding of, the basics of military veteran culture, how to best listen and support somebody. And then the understanding, I think, also of their role. That, again, we don't expect you to, we tell this to people when we train them, like you are not their therapist, you are not responsible for them, but you may be the person that they happen to interact with at the library, in a workplace, in a school, in your neighborhood, all sorts of different places. You just may be the person that maybe they open up to, or they feel safe with, or it just happens to be that this is when they sort of hit their most challenging point, and you are the person who's there. So if you are an open door for them, if you can listen and then tell them, you know what, I don't have all the answers for you, but I know that there are services and support available to connect you to resources, that you are not alone in this, and we will get you connected. So if you can be that person for someone, and anyone can be that person for someone, and then that to me is what we're really striving for, which is even with our Be Connected program, even though we have the capacity to push people to a centralized phone number for the entire state, at the same time, we don't want to have one door. We don't want to have one door that everybody has to fit through. We want thousands of doors, and those doors are people, people who have the knowledge, skills, and confidence to help. So everything that we do, and I know everybody's doing a lot in this area, but everything we do to build that knowledge, build those skills, and build that confidence of our community helpers is really essential in us being able to reach people, because there is no way for us as centralized big systems and organizations to reach each and every person. Our best chance of doing that is to have those thousands of open doors across our states. Next. I just wanted to kind of share a little bit about sort of how we have things structured and some of the things that we've been able to pull in that might maybe give you some ideas to consider. So this is our Be Connected team of teams. So we have regional navigators who are community-based. We partnered with a experienced behavioral health agency for those roles. We have a support line. That was actually the very first thing we stood up for Be Connected back in 2017, was literally one person answering the phone. And they answered 5 calls the first 2 weeks of April 2017. And we're now closing in probably on close to 60,000 encounters for the program over the past 4.5 years or so. We have actually positions in we have 3 VA healthcare systems, and all 3 of them have designated VA peer support specialist positions to work with Be Connected, which has been a wonderful asset to the program. So that's something that perhaps you already have. Most of them have peer support specialists for suicide prevention. So you might see if those are people who can work more closely with your efforts. Then we also have career specialists, and they are specifically focusing in on service members, veterans, and family members who are navigating a career, either restarting their career or transitioning out of the military, or dual career for Guard and Reserve, or just whatever that situation people might be in. And then we have our risk reduction operations team, which I mentioned earlier in terms of that sort of the segments of the population that are higher at risk. So we have formed a specialty team to focus on those segments of the population. Something that we have just moved into in the last year, we've hosted AmeriCorps Vistas in the past, and a couple of AmeriCorps members in the distant past, but that hasn't been something that's been part of our program in the recent past. And so, but we are now partnering with Northern Arizona University and several community-based locations for AmeriCorps members to basically be part of our Be Connected team and function as resource specialists to connect them into the greater Be Connected program. So that has been going really well, and we're excited about continuing to grow that option. And then we have a community engagement team that focuses on those helpers, organizations. So these are sort of all these elements. We have about 400 Be Connected partner organizations. We have mapped over 3,000 resources to be matchable to the needs of our service members, veterans, and their families in our state. So some of the different sort of angles that you might consider as you continue to grow your programs in your states and communities. So just some final points to keep in mind as I wrap up. So just consider the resource and support needs of everyone in the family. Kind of be careful about sort of falling into that sort of slot of it's sort of all becoming about the service member or veteran. Of course, we want to attend to their needs, but also making sure that we are looking at the needs of everyone in the family and their own individual needs, as well as the family as a whole. We want to take that inclusive view of needs and social determinants of health to say, okay, behavioral health may be a need, but what might that look like? How might that be presenting? And what needs might we need to address first that are really immediate needs in order to get to a place where they can actually address the underlying behavioral health need that is driving the situation. And then as much as we can, create clear pathways to help people and families navigate systems and resources. I mean, I just feel like we're really fortunate in the roles that all of us are in, and as being part of these state teams, we get to have an influence in what that experience is like for service members, veterans, and families in our states and communities. And that's a really, it's a huge responsibility. It's also a really powerful thing to recognize that the work that you do will have a direct impact on thousands of people over time. And so whatever we can do to really look at the state of things now and what could potentially be done to smooth those things out, to make that access as easy as possible, I think is a wonderful opportunity in our role as state team members. So next slide is my final slide, which has my email address on it. You are welcome to contact me, but I will wrap up here, and thank you so much.
Thank you very much, Mrs. Winkle, for that very well presented and informative session presentation on finding the right resources at the right time. Arizona is certainly very fortunate to have your organization with you at the helm with these services for family members and veterans in your community, as well as service members. I wrote down a few notes as the audience began to think about their facilitated discussion question. Who have you had the opportunity to refer a family member for services? Some of the notes that I wrote down were the custom blend of resources that your agency makes available to address the unique needs of every family member that may or may not be related to the service member. That's amazing. Being able to keep your messaging simple, being able to normalize the messaging so that it's not necessarily talking about a mental health issue or a crisis, so to speak, or something dealing with suicidality. Also opening the widest door possible so as many people can get in as the resources allow. And finally, again, looking at the entire person with regard to the social determinants of health, treating the entire person. So having said that, at this time, we'd like to hear from you, audience. Why do you think it's important to those of you who have referred family members for services? You can turn your mic off mute, and we have about 5 minutes for a discussion. Whoever would like to talk about, and I see Dr. Cotton has a raised hand. Just talk a little bit about who you've been able to refer for services and why was that so important?
Well, I think it's everybody's job. I'm not specifically in that line of work as a counselor or therapist or anything like that. But as a fellow veteran, if I see a fellow veteran in trouble, you know, referring them and getting them into the right people, and having had family members contact me about their loved ones has really been helpful to have contacts throughout the state. I guess I had a question, if it's okay to ask a question, Barbara. I wanted to, Nicola, I wanted to know, you talked about the characteristics of the veterans and their family members who have completed suicide. And I'm taking it that those are the ones who are connected up with the VA. What do you know about the veterans or their family members who have completed suicide who weren't connected with the VA? Do they have the similar characteristics in terms of a disability, or, you know, is there anything different about them? And thank you for your presentation. This is really wonderful. So thank you.
Oh, thank you so much. So actually and you know, as for all of us, unfortunately, you know, our data is what our data is, but we are fortunate. We have a great relationship with our Arizona Violent Death Reporting System here. And the analysis that we're doing on the data is not necessarily tied to those veterans who were receiving VA care. I mean, some of them would and some of them wouldn't, but it is actually from our Arizona Violent Death Reporting System. So that's not going to be 100% of veterans who died by suicide, of course. That data point just isn't always known, but it is better data than we've had in a long time. They've done a lot of work to, so all those data points that are sort of captured as part of the Violent Death Reporting System, we're then able to separate out those who are known veteran status, and they've done as much as they can to get as much clarity as they can about, and I think they're capturing more people who have veteran status than maybe they did before. So that would definitely be a mix of VA enrolled and non-VA enrolled. And then what we're doing is essentially analysis down to the zip code on those known veteran suicide deaths and the characteristics that go with that. And then also using the American Community Survey to get down to the census tract in terms of sort of known things about the population by census tract. We have a wonderful data team that is putting this all together into an index tool, basically, that is then like assigning risk to each of those. There's like 9 or 10 different factors that then are combined into helping us. And what we've done is identify like 5 segments of the population that are, in Arizona at least, are the ones that we are most concerned about in terms of risk of suicide. And that's a combination of age, gender, geographic location, things like disability status, unemployment, or employment status, those sorts of things. So we're looking across all those different factors and then combining them into an index tool, basically.
Thank you so much. And again, wonderful presentation. Thank you.
Oh, thank you so much. I appreciate that. Let's see.
Thank
Did you want me to answer these questions, Barbara, or did you want to save them for the end?
Yes, I see the question about where does the funding come from Cheryl.
Yeah. Do you want me to answer that now?
Yes, please.
Yeah, absolutely. Okay. Thank you for your comment, Cheryl. So Be Connected started, I mentioned we started with just one person answering the phone, and our initial funding came from, basically we have a fund here in Arizona that's generated from veteran and patriotic license plates that our Department of Veteran Services can do grants out to organizations that serve the veteran community. So the very initial funding came from that. Our first 3 navigators actually came from a private foundation. So that funding was really crucial in terms of just getting the program off the ground, demonstrating utility. Like, you can set up a phone number, if nobody calls it, it really doesn't matter that you did it, right? So first you just have to demonstrate, like, is this something useful to our community? Is it something the community will use? Definitely showed that that was the case. And then from there, we are at the point now where we basically have funding from the VA, and it's actually written into a line item in our state budget now for Be Connected. And then we're also fortunate to have support from different private foundations and corporate partners as well. But the bulk of the Be Connected program itself is funded by that state line item and by our VA partnership.
So thank you very much again, Mrs. Winkle, for your presentation. Thank you very much, audience. If you have any additional questions, please feel free to put those in the chat, and we promise we will get all questions answered, and also a copy of the slides will be made available to all attendees. Thank you. So we have more awesome information for you coming up. This poll question simply says, between 2004 and 2010, the predicted probability of divorce for active Army enlisted soldiers with at least 5 years of marriage, is it A, 7.2% for those without PTSD, 10.8% for those with PTSD? Is it B, 17.6% for those with PTSD, 21% for those without PTSD, C, 3.5% for those without PTSD, 6.8% for those with PTSD. Finally, is it D, 22.3% for those with PTSD? And I think that's 35%. I have a something in my way there, but I think that's 35%. Yes, 35.8% for those diagnosed with PTSD. So it will certainly be interesting to find out what that answer is as we move forward to hear from our next subject matter expert. It gives me great pleasure as we move to the next slide to introduce our next presenter and subject matter expert. It is Mr. Dwayne France, MA, MBA, LPC. Mr. France is the Director of Veteran Services for the Family Care Center, a private mental health clinic in Colorado Springs, Colorado. He is also the Executive Director of the Colorado Veterans Health and Wellness Agency, a 501c3 nonprofit professionally affiliated with the Family Care Center. Upon retiring from the Army after a 22-year career, including 5 combat and operational deployments, Mr. France began serving as a clinical mental health counselor in 2014. He is a member of the inaugural class of the George W. Bush Institute Veteran Leadership Program, a program that supports individuals from diverse sectors across the country who are motivated to increase their impact in helping our nation's veterans. In addition to his clinical work, he also writes and speaks about veteran mental health in a wide variety of settings. He has presented at national conferences on mental health and wellness in the military population. He has authored 3 books and is the founder and host of Headspace and Timing, a blog and podcast that brings the information from the clinical community to the SMVF community. He has been published in numerous local and national media outlets and writes an online column for Counseling Today. Please join me in welcoming the distinguished Dwayne France. It's all yours, Mr. France.
Thank you, Dr. Lattimore. I really appreciate that. Always interesting. We provide the intros, but then we have to sit through the intros. And I'm quite certain that everyone has just as distinguished experiences as many of us. And this is where we've all been at. I really appreciate the responses to the poll question. I recognize that it was a little bit more of a quiz question than a poll question. But very interesting to think that perhaps we're engaging in some confirmation bias, but the majority of those who responded in the chat indicated that it was 22%, so more than 1 in 5, those without PTSD, and over 35% for those diagnosed with PTSD. Perhaps you'll be encouraged to hear that it's not as bad as all that, but it is pretty bad. The correct answer is actually B. And if we look at 2004 and 2010, this was during the height of the conflicts, especially in Iraq, and then emerging into the height of conflicts in Afghanistan between 2009 and say 2012. And so it is 17.6% was the predicted divorce rate for those without no diagnosis of PTSD, nearly 1 in 5 for those diagnosed with PTSD. I think sometimes we might often see that as a mental health counselor, I often say that if I was a medical doctor, I'd be an emergency room doctor. Everybody's coming in to see us bleeding from 1,000 cuts, really talking about what Nicola was talking about as far as some of those red zone issues. And so while it's not as bad as 35% with PTSD, still 1 in 5 enlisted service members diagnosed with PTSD has a probability of divorce is still significantly high. I think that demonstrates a lot of the strain that service members are under the strain that they're under, that their families are under. And yes, Dr. Cotton, it is also jaded. I was hoping that we would redeem ourselves, but perhaps our cynicism revealed itself a little bit. But really it's a cynicism in that jaded, because we see it. We see that especially relationships and families are so challenged, especially when addressing these issues. Next slide. So I'm going to be talking. It was really great to be able to hear what Nicola's talking about as far as engaging family and care on a systems level, the great stuff that they're doing in Arizona. And I'm going to be talking about it from sort of an individual level, what we as individuals can incorporate into our programs to support families engaging service members into treatment. So Nicola giving that macro level, I'm going to be giving some of the micro level, a little bit of the individual. I'm going to be talking about 2 different categories today. One, the family's role in initiating care, and then the other, the family's role in supporting ongoing care. And so as I engage in different conversations and webinars, even being available for families on social media, one of the main questions that I often get is, how do I get my service member into care, my veteran, the service member or veteran that I care about? I hear this from parents, I hear this from siblings, I hear this from spouses, I hear this from children. Is so-and-so is hurting, so-and-so isn't doing very well, how can I get them into care? And so the family's role in initiating care, I'm going to talk about a program from the VA called Coaching into Care, and some really great resources there, but then also helping the family understand more about what their service member is going through. And then once the service member is in care, what is the family's role in supporting that care if they do get into care? And so really want to talk a little bit about the outcomes of family involvement, but then a way that professionals or case managers, peer specialists who are supporting professionals or integrated with professionals, how they might be able to continue to engage the family in the care. Next slide, please. So first, when we're looking at the family's role in initiating into care, and I'd love to hear in the chat if anybody has heard of the Coaching into Care program, has had experiences with the Coaching into Care program. So this is a program out of the Rocky Mountain MyRec. I'm located out here in Colorado, and so the Rocky Mountain MyRec has a program that's called Coaching into Care, and it's not the support line, it's not a crisis line. This is a phone number, a website where individuals can specifically get connected to be able to talk about how to get their service member veteran into care. So it provides support and problem-solving assistance for family members and others concerned about a veteran. It coaches family members. It doesn't connect. It doesn't create an intervention. So you're not going to be able to get them on the phone and then hand the phone off to your veteran and say, "Hey, talk to them," so they get you into treatment. This is more about how they can help someone, coach someone into how to have that conversation. Referrals to care for veterans and family members, and information about available programs or enrolling into VA care. The other aspect is really to help family members understand what their military and veteran service member is experiencing. And so we often talk about the need for cultural competence as providers, as mental health providers, or as case managers, as support individuals, that we need to be able to have military cultural competence. One thing that we don't often think about is the other side of the coin is, does the family member have sort of mental health competence? Do they understand, because they've got military cultural competence perhaps falling out of their ears, but do they really understand the mental health aspects? Do they understand the things that we know, the different social determinants of health? And so here's a quote from Shepard and Bannigan and the colleagues. Engaging family members through multiple means, including education, may be an important mechanism by which to address barriers to treatment initiation and possibly adherence problems observed amongst post 9/11 service era veterans. And so it's this idea of, the more that people know, the more that family members know about what's going on in their service member's head. Why are they acting that way? What's happening here? You know, what is the difference between traumatic brain injury and PTSD, and what is the combination of the two, and how is that exacerbated by substance use? So these are really two of the things that, as we're talking to people about coaching into care or initiating care, is how do we have those conversations, and then how do we develop understanding? Next slide. So again, coaching into care, www.va.gov/coaching into care. Just do coaching into care in VA in a search engine, and it's going to come up. And so coaching into care has a number of different things that family members have to be aware of to be able to support their veteran or service member into care. So first is being respectful and calm during conversations. Because this is, you know, many people often, it gets to a place of crisis and there's emotions on all different sides, right? But trying to force someone, or being overly emotional, or just, you know, making ultimatums can be really challenging if you're trying to convince someone to seek care. The second thing on the bottom left, allow the veteran in your life to decide whether or not they want to talk about what they've experienced or what they're currently dealing with. This can be a challenge, especially with perhaps spouses or maybe children that want to know what their service member experienced. They want to, and maybe even feel like they have a right to know. I'm experiencing the aftermath of this service. I feel like I need to understand this. And sometimes if the veteran hadn't fully processed what they experienced, or they have certain ideas around who should or shouldn't know. I have a lot of veterans that say, I don't want to share these things with my family because it makes me feel bad, and I don't want to make them feel bad. And so the service member or veteran may see it as, I'm protecting you, the family member, but the family member may see it as, you're hiding something from me, or I want to share as much from you. And so really, as a family member, helping them understand that it's up to the veteran to decide whether they want to share or not. We see this with a lot of Vietnam veterans. I am one of the multi-generation combat veterans. My father and 3 of his brothers all served in Vietnam between 67 and 70. And all of them had very, very different experiences. I know very little about my father's experience in Vietnam. I maybe towards the end of his life, we lost him to natural causes in 2017. Towards the end of his life, he started opening up more, incidentally, after I had deployed to combat. But before then, I knew very, very little about what he experienced. His brother, on the other hand, who's a door gunner in the 101st, was very much willing and able, and often to a great extent, willing to talk about what happened in Vietnam. And so we really need to be able to understand what individuals may want to disclose or not disclose, and not to try to force it on them. And then a third thing that Coaching into Care really tries to get across is say we need to be patient. We need to understand that it's not going to be the first thing that we often do. It takes more than one conversation before most people accept the idea of seeking care. I have a client that came to me one time, was referred to me from a community provider. So he came in with my pamphlet, and my pamphlet, and it was all crumpled up. And I asked him how he had heard of us. And he said, well, I went to this community provider and they gave me your pamphlet and said, go see you. So he said, I threw it in the front seat of my truck, and it was sitting there, and my wife was there a couple days later, and she picked it up and she said, oh, what is this? And the client said, oh, this is nothing. And he threw it in the glove box. Then the next day or 2 days later, he says he goes to work and he finds that she had gone into the glove box, got the pamphlet, folded it up, and put it in his lunchbox after they had had an argument the night before. So he crumpled it up and he sort of threw it on the counter when he came back. And then finally, several days or some period of time after that, he said he found it laying next to his nightstand, uncrumpled, with my number circled on it 3 or 4 times. And he realized that I guess that means I needed to reach out to talk to you. And so even after 4 times, 1 from the agency and then 3 more times from his spouse, really trying to say, hey, go see this person, it's going to take some time before someone actually reaches out to care. Next slide. There are some don'ts that the Coaching into Care program really suggests when we're talking about initiating care. Don't argue or attempt to talk a veteran out of their feelings, thoughts, and or emotions. That's one of the challenges I think that a lot of veterans might experience, is they're not sure whether or not they have a right to think the things that they're thinking or feel the things that they're feeling. And so it can be validating or reinforcing if someone says, oh, get over it, get past that, people had it worse than you. These kind of things are really invalidating to somebody that's struggling with these things. Another thing is giving advice, right? I mean, this is one of the things, is you should do this or you should do that. Giving advice unless the veteran specifically asks for it. And so giving advice can really be sometimes seen as coercive. You can inquire, you can support or engage, but don't try to tell veterans what they should do. Sometimes that was some things maybe we had problems with when we were in the military, is being told what we should or shouldn't do. But really trying to give that advice isn't always the best thing. And the other thing is really, and I see this a lot with spouses that I work with, or veterans that describe the experiences spouses they work that their spouses, is that the social withdrawal or isolation is taken personally, like it's a personal rejection of the spouse. And again, this is before someone really gets into care, and helping them understand that the veteran may have different reasons for wanting to isolate. I know some veterans that say, I need to pull away. I need to hurt you to help you, hurt you emotionally, so to speak, but I need to push you away to protect you from me, to protect you from what I'm feeling. I need to be bad in order to be good, kind of thing. So this is a paradox a lot of veterans really experience, is I need to isolate so that I'm not hurting my family, but in that isolation is hurting more of the family. So really, these are the kind of things that if you have a family member who reaches out to your organization, or a member or a partner of yours, and says, how can I help somebody get into treatment? Coaching into Care is a great program, and that Coaching into Care program will really talk them through some of these things. Next slide. The other thing about initiating care is helping the service member, or excuse me, helping the family member understand more about what's going on. Understanding the conditions that the veteran is experiencing is critical to providing accurate support, right? So on the left here, you'll see sort of a conceptualization of sort of the comprehensive veteran mental health model. So those things on the bottom are things that as mental health professionals, we can diagnose for. It's the medical model of mental health. Post-traumatic stress disorder, traumatic brain injury, substance use, emotion, depression, anxiety, and anger, emotional dysregulation. So if someone is experiencing, and not everyone has PTSD, we know that the prevalence is only from 11 to 20%. But maybe a veteran is struggling with anxiety and depression, but the family member thinks it's PTSD. It may not be connected to a trauma. So putting somebody or suggesting that somebody go see somebody to do EMDR if there's no trauma there, but it's really about emotion dysregulation, then understanding the differences behind these different things. On the top, you'll see something that's really emerging to be known as transition stress, which may be a little bit, it's non-medical. There is no diagnosis for a lack of purpose and meaning. Moral injury does not have a diagnostic criteria in the DSM. There's no medication that will improve someone's marriage as much as my wife might want there to be. But there's these things here that are beyond just the military and veteran, the psychological experience, but really post-military life. How can I get more purpose and meaning? What is moral injury and how it might apply? How is a veteran struggling to meet their needs when the military supported their needs? When I was in Iraq and Afghanistan, I never had to worry about where food was coming from or where my water was coming from. But now I have to figure out how to do a rental contract and meet all of these different needs. And then finally, relationships. So understanding the comprehensive nature of what the service member and veteran is experiencing can be very beneficial for the family member who's trying to help them coach into care. They may not be struggling with PTSD, TBI, or depression at all, but we're saying, hey, go to the VA and get medications. Well, that's not helping if they don't feel like their life is fulfilled in post-military life. It's also necessary for us in the community to provide resources and materials to aid in understanding about these conditions. Again, it's one thing for if we as providers, I'm talking providers broadly, case managers and things like that, if us as providers are not military culturally competent, we need to go seek resources and materials to aid in our military understanding. Our family members, they need the same kind of resources to aid in their understanding about these mental health conditions. They understand it from an outcome standpoint because they're living it every day. But what really is post-traumatic stress disorder? How does traumatic brain injury perhaps exacerbate addiction and things like this? And the other thing is really to connect to other caregivers and family members with similar experiences. So really being able to provide wider support. Next slide. So education and awareness resources, the VA Caregiver Support Program has really done a lot to be able to support caregivers, physical health givers, as well as psychological health caregivers. If you're not familiar with PsychArmor, psycharmor.org, I highly suggest that you connect with them. They have a wide range of resources to help family members and providers and individuals understand more about what these conditions are. And then one of the leading national organizations to be able to provide understanding about these conditions is the Elizabeth Dole Foundation and their Hidden Heroes program. And so if you go to the Dole Foundation website, you can find a lot of different resources for caregivers, for family members who are trying to support their family member, their veteran and service member through some of these challenges. And when it comes to group and support communities, there are some very large national ones. Most large areas definitely have groups, and it might take a short search. But again, the Dole Foundation, they're Hidden Heroes communities. So they have an online community, and most of those online communities also are connected to local groups of caregivers that are helping people experience or helping other caregivers who are experiencing some of these challenges. For a lot of my military and veteran clients, I ask, I'm like, is your spouse connected to other spouses, other family members that are experiencing these things? And then, of course, the National Alliance on Mental Illness has chapters, both state and local chapters in many different places, where you can reach out and see if they have a military and veteran caregiver support group. So these are two ways to really help them develop understanding about what the situation is. Next slide. Next, I want to talk a little bit about the family's role in supporting ongoing care. So the research does show that family involvement and social support are associated with recovery from mental health disorders. Family members are a key health-related social support. We know that's the case for physical health, and that's the same for clinical health. And then recognition of family environment resilience factors, they provide key health promotion pathways for both healthcare and mental health providers, have guided family-centered care and healthcare settings. So again, incorporating the family into care can really be beneficial for the service member and veterans care themselves. Next slide. Some of the research indicates that veterans who are satisfied with their provider's involvement of family members in their participants' care reported lower depression severity and better medication adherence. Now, of course, yes, we do have to, as providers, understand that HIPAA, we have to make sure that the client themselves, the service member and veteran, really needs to be able to give that consent and be able to incorporate their family, but also even encourage their family into this. Another study indicated that negative association between social support and post-traumatic stress disorder and social support has been conceptualized as a key component to bolstering resilience to trauma. So the more connected we are, the less isolated we are, the better the outcomes, the more resilience is going to be developed. And then a study from the National Academies of Science and Engineering and Medicine, which came out in 2018, showed that OIF, OEF, O&D veterans, so post 9/11 veterans that have significant others who support their seeking treatment are much more likely to use VA healthcare services than veterans without such support. And we do know the numbers coming out of the VA are that those veterans who are more likely to be engaged in VA care have less likelihood, because of the comprehensive nature of VA care, less likely to engage in lethal self-harm than those not engaged in the VA. So long story short here is, just like anything else, if you have a family member that's downplaying or ridiculing your treatment, or sees your treatment as a nuisance, or doesn't recognize any gains that are made in treatment, somebody who's less supportive of that treatment, then that veteran or service member is not going to continue to engage in treatment. If you have family members that are supportive and engaged and ongoing, and not want to know everything you and the therapist talked about, but really instead is just trying to say, I'm really glad that you're getting help, that really leads to better outcomes than those that don't have that kind of support. Next slide, please. Here, this is, again, from that report, from the Evaluation Department of Veterans Affairs Mental Health Services. These are some of the things some of the distinctions that mental health care is differences than medical health care. There's greater stigma attached to mental health diagnoses. There's more frequent coercion of patients into treatment, especially for substance use problems and concerns. So more, interventions, get help or I'm leaving you, those kind of things. Mental health care has a less developed infrastructure for measuring and improving the quality of care. And then there's the need for greater linkages among the multiple clinicians, organizations, and systems providing care to patients with mental health conditions. Again, that first bullet, that second bullet, and that fourth bullet are all ones that the family member can be engaged with. The family member can either increase the stigma attached to mental health or decrease the stigma. The family member can engage in that coercion or reduce some of that coercion. And again, if we think about the greater number of linkages among multiple clinicians, so someone who has post-traumatic stress disorder, traumatic brain injury, who's using substances to address some of those concerns, who's anxious, depressed, and angry. So they probably have a medication provider. They probably have a neurologist or some type of neurological support for their traumatic brain injury. They probably have a primary therapist addressing their trauma reaction. They have a substance abuse therapist addressing their substance use. And again, that's at least 4 clinicians, much less if that individual is homeless, if they can't find a job, if they're isolated. The more people we add into this, usually it's the family member, especially a spouse or a child, who's really trying to navigate all those things. And so as Nicola was talking about earlier, is the person who is most needed to coordinate those things, the individual themselves, the service member and veteran, may be least likely or least capable to be able to do that. And really getting the family member to be able to coordinate amongst all of these, just these appointments, much less all of these different clinicians, probably from different systems. The family has a significant role to play when it comes to supporting mental health treatment and support. Next slide, please. So really looking at the methods to engage family members into care. Decades of research understand that we really need to know about what the situation, what all of the relationships are between the service member, their spouse, their partner, their child, for example. If you add in parents who are engaged in this, and it just gets that more exponentially systematic. But we really need to think about a family-centered approach from the system. If the child is watching the spouse and the service member or veteran always in a contentious relationship, that impacts them. Same thing maybe perhaps with a close relationship between a spouse, partner, and child, and the service members feels like they're left out. So really we need to understand what this family system is to be able to engage that. And again, this Nicola, we did have a great meeting to be able to talk about this, but my first bullet here was one of the repeated points that she's talking about is resist thinking about service members and veterans as separate from their families. And Nicola's corollary point was resist thinking about families as just an adjunct to the veteran. So we really need to think about them as separate and individual, distinct. We need to identify and evaluate effective strategies for family engagement across service settings. And so family engagement may be different for a medication service provider than it is for a peer support specialist, than it is for a substance abuse counselor. And then we need to consider barriers to care from the perspective of the family's ecological niches. And so we need to understand more about that individual's family. If they have a contentious relationship with their parents, for example, then their parents probably are not the ones to bring into this family support. Next slide. Really, we need to help them self-advocate. I often talk with my clients on how to explain these things or discuss these things with families. I will provide resources to them to be able to share with their families. We need to be able to balance family involvement with client satisfaction. Again, if they're in a contentious relationship with a significant other, and that contentious relationship may be exacerbating some of these conditions, then we're not trying to force something in the therapeutic relationship that doesn't belong there. And really more on that, we need to be aware of potential drawbacks and obstacles to family involvement. I actually had a client at one point in which his spouse would come in, he would come into the waiting room, and then he would find that after he came in, his wife would sit out in his car. After the session started, she would come in and she would listen at the door and want to listen to what was going on in his therapy sessions and leave before he came out of the session in such a way so that she was eavesdropping, and we had to have a conversation. I had to help him through that conversation of how to have that conversation with his wife, his spouse, to be able to really say that, you know, there's some things I want to talk about in therapy, and not really engage that and to be able to have that privacy. So we really need to understand the dynamics of a client clinician, or excuse me, a client family relationship. Next slide, please. So really the goal is, like Nicholas said, at the systems level, and as I'm saying here, it's not just the veteran themselves, it's not just the service member themselves, and it's not just the family member. It is an integrated process. And so if we really want to be able to engage the service member, the veteran, in a life of wellness, we have to incorporate their family. So next slide. and click once more. I think I had some animations here. Thank you. I recognize that our time is coming to a close, and I want to be able to have a chance for a chat. These are some of my references, but feel free to take a screenshot there. You can contact me through email, website. I'm a big guy, both in real life and online. So as long as you spell my name correctly, you wouldn't be too hard to find anything that I'm doing. Be happy to talk a little bit more about how I have encouraged families or service members in supporting their families in treatment. I will turn it over to Dr. Lattimore.
Thank you very much, Mr. France, for also providing us a very well presented, very informative session on engaging families in the treatment process. You told us a little bit about patience, understanding, respect, connect, and connecting that's related to that priority area 2 for those in the Governor's Challenge. So now we're going to hear a few questions on this topic. I see Sandra, is your hand up, or is that still from the last time?
Well, your hand's up, so you got to ask a question now.
So do you have any comments, Sandra? What do you think about this topic?
Well, I think it's really much deeper than people think. And I also think that we haven't begun to see, we've yet to begin to see some of the issues, especially in the younger people who are family members of veterans who've had multiple deployments, who've had PTSD, depression, or other mental health problems, and just being disabled, not being available to the child or to the spouse. And so I think a lot of the kids are aging out of some of the school-based programs. And I think that I'm in a college setting, I think that we as college educators have got to think about this, in terms of looking at our student population. We look at what students are veterans, but I don't think that our university at least looks at what students might be the son or daughter or brother or sister of a veteran or a spouse of a veteran. And I think that's something that we need to really think about.
No, I think that's a great point. Apropos to me, because my daughter is a senior, my son's she's a senior in college, and he's going into his junior year. So I have 2 college-age kids. When I started to deploy in 2006, they were in kindergarten and 1st grade. When I stopped deploying in 2013, they were approaching high school, right? And so if we think about adverse childhood experiences, especially if someone is struggling with mental illness in the home, substance use in the home, perhaps justice involvement in the home, situational or chronic domestic violence in the home. So again, all of these factors that we see in the military and veteran population, children in that home were engaged in many, many more adverse childhood experiences. Not to mention the fact that people that are multi-generational combat veterans like me and my younger brother, having seen that from my father and his brothers and things like that. So I think that is a really good point. I do know that both of the universities that my children go to do consider family members as part. They have access to the veteran programs just as much as the veterans themselves. So the veteran centers on each of their campus do have an outreach. They do consider them military affiliated and do have some programs or at least maintain some connections and recognize them and have the same kind of support. So that's a great point. Thank you.
It's wonderful. Thank you.
Thank you very much. On that note, we'd like to say thank you very much for our 2 amazing presenters, Nicola Winkle and Mr. Dwayne France. Thank you very much to our audience for taking this time out of your day to spend with us to hear this information on engaging and working with families. The slides will be available at a later date. If there are any lingering questions, please place those in the chat. And I see our technician is reminding everyone to take a couple of minutes to fill out the evaluation. That has been placed in the chat as well. So if there's nothing else at this time, we would give you back about 3 minutes of your afternoon. Have a wonderful evening, everyone. Thank you.